Imagine surviving a really grueling, say, 4-hour dialysis session. Or maybe you've just woken up from a pretty complex outpatient surgery.
Right. You're just completely wiped out.
Exactly. Your body is totally exhausted. You're probably slightly disoriented from the medication, and, you know, you haven't eaten since yesterday.
Yeah, the fasting is rough.
It really is. So the clinical team comes in, they clear you, the doctor signs the paperwork. All your personal belongings are packed up in that little clear plastic bag they give you.
Yep, the classic hospital bag.
Right. You are medically officially ready to go home and just sleep in your own bed.
Which is all you want at that point.
All you want. But instead of recovering, you end up spending the next 3 hours trapped in this hard plastic chair in a hospital lobby.
Under those awful buzzing fluorescent lights.
Yes. Just sitting there wondering if you have been entirely forgotten by the outside world.
Cool.
So today we are looking at a hidden medical crisis. And it doesn't involve scalpels or misdiagnoses.
No, it's much more mundane than that, but just as critical.
Exactly. It involves a simple car ride, and we're going to look at the massive, invisible system that completely falls apart the moment you need it most.
It is honestly the ultimate paradox in modern healthcare.
I mean, how so?
Well, think about it. We possess the technology to perform robotic surgery with, millimeter precision.
Right. It's incredible.
It is. Yet, we routinely fail at the seemingly basic task of just moving a medically vulnerable human being from the hospital lobby to their living room couch.
Which sounds so simple on paper.
Exactly. But that gap, that terrifying void between medical discharge and actually arriving home safely, is where some of the most profound patient trauma occurs.
And that gap is exactly what we are unpacking in our deep dive today for SwiftAid. We are pulling back the curtain on the world of non-emergency medical transportation.
Which you'll hear us call NEMT today.
Right, NEMT.
Yeah.
But we aren't just talking about any ride here. We are specifically zeroing in on something known as the will call return ride.
This is where things get really complicated.
They really do. So if you've never been stuck in this system, let me explain how this works for you. When you have a medical appointment, getting there is, it's relatively easy to plan.
Because you know the start time.
Exactly. You schedule a ride for 9 a.m. The driver picks you up at 8:15. You arrive on time. It is a fixed event on a calendar.
Right. It's completely predictable.
But the return trip, that is a will call ride, which means it is a trip that is only activated when you are completely ready to leave.
Meaning there is absolutely no fixed time attached to it in advance.
Right. Now, if you're listening to this and thinking, well, that seems silly, why not just schedule the return trip for an hour after the appointment begins?
Right. Just lock it in.
Yeah, I completely get that logic. It makes sense. But it simply doesn't work in reality. Healthcare fundamentally refuses to follow precise timetables.
It's biologically impossible to guarantee a timetable, honestly.
Right.
Yeah. I mean, human bodies don't operate on a commuter train schedule. You can't just predict it.
Exactly. Because let's say you have an appointment at 10 a.m. You might be done by 10:30.
Or the doctor might listen to your heart and say, I'm hearing something I don't love. Let's run an EKG right now.
Right. Or the on-site pharmacy is backed up and it takes an extra hour just to fill your new prescription.
And suddenly that quick checkup is stretching way past 1 p.m.
Exactly. Think about it like making a reservation at a highly exclusive restaurant, but you have absolutely no idea what time of day you'll actually be hungry.
That is a perfect analogy.
Right. Because if you schedule a fixed ride home too early, the driver arrives and you're still in the MRI machine.
And then the driver either has to sit in the parking lot, which completely destroys the schedule of every other patient on their route, or they abandon you and leave.
Wow. Yeah. But if you schedule it way too late just to be cautious, you are the one left stranded in a lobby for hours after you're actually done.
So the will call system was designed to handle this exact medical fluidity.
It was meant to be the solution.
Right. And this brings us to a massive systemic illusion that we really need to shatter right now. We call this the will call paradox.
The will call paradox. Tell me about that.
Well, the entire intention behind will call is to provide flexibility. But without an incredibly rigorous coordination system running in the background, that flexibility instantly morphs into massive systemic uncertainty.
Right, because nobody actually knows what's happening.
Exactly. There is this pervasive, almost dangerous assumption in healthcare facilities that a will call arrangement somehow guarantees a fully staffed, perfectly equipped vehicle is just idling around the corner.
Like it's just waiting for a single phone call so it can swoop in and pick you up?
Yes.
It's basically the uberification of our expectations, right? We hit a button on our smartphone, and we just expect a car in 4 minutes.
But NEMT is not rideshare, not even close.
No, it's completely different.
It is not an on-demand service. It is a highly regulated, complex logistics network. The core disconnect here is that a lot of well-meaning medical staff treat call transport when the patient is done as a single, simple action.
Like flipping a switch.
Exactly. But a successful will call trip is not one action. It actually requires 4 distinct, highly vulnerable phases to succeed.
Okay, break those down for me. What are the 4 phases?
First, you have to arrange the return trip days in advance so it's actually in the system.
Right, you can't just call in the day of.
Exactly. Second, the facility has to physically and operationally prepare the patient for release.
Okay, getting them packed up and discharged.
Yes. Third, someone has to actively and successfully activate that ride with the dispatcher.
Which, as we'll see, is harder than it sounds.
Oh, absolutely.
Yeah.
And fourth, you have to confirm the actual physical handoff of the patient to the driver.
Wow.
Yeah, so when people lump all 4 of those complex phases into this vague idea of just call them, the entire system collapses.
I want to stop right there because that is a massive realization. We aren't just dealing with a lack of vans here.
No, the vans are usually out there.
Right. If I'm understanding you correctly, we are looking at a systemic communication breakdown.
That is exactly what it is.
Which means if we want to figure out why patients are waiting hours for a ride, we really have to look at everyone involved in this ecosystem.
We have to look at the different lenses through which people view this exact problem.
Right, right. So let's put ourselves in the shoes of the healthcare facility first. If I'm, say, the charge nurse at a busy dialysis clinic, what does this look like to me?
Well, if you are that charge nurse, your primary overwhelming mandate is clinical care.
Right. You're focused on the medicine.
Exactly. You are looking at blood pressure, fluid removal rates, infection control, and charting. You are making sure the transition out of your care is medically safe.
Because that's literally your job.
Right. Transportation in the grand hierarchy of a nurse's day is viewed as a post-care logistical headache. It gets pushed to the periphery because, frankly, they went to school for medicine, not dispatch routing.
Okay, I hear that. I totally get it. But surely when a patient is sitting there for 3 hours, it becomes a clinical problem for the nurse, doesn't it?
Oh, it becomes a catastrophic operational problem. Imagine the domino effect in a major hospital's emergency department, for example.
Okay, set the scene for me.
A patient is discharged, right? But their ride doesn't show up. That patient is now physically occupying a bed.
Oh, wow. And they don't even need to be there.
Exactly. And because that bed is occupied, the incoming ambulance patient has to wait in the hallway.
Which causes a backup.
A massive one. Because the hallway is full, the waiting room backs up. Suddenly, highly trained trauma nurses are spending 45 minutes on hold with a transportation broker trying to track down a minivan.
I mean, that is a terrible use of a trauma nurse's time.
It really is. The pressure mounts. Shift changes happen, creating immense confusion over who called who.
Right, the morning shift leaves, and the afternoon shift has no idea what's going on.
Exactly. And eventually you get this terrifying pressure to just move the vulnerable patient outside to the curb, totally unconfirmed, just to physically clear the space.
Wait. They actually do that. They just push sick people outside.
It happens way more than the industry wants to admit.
That's horrifying.
It's driven by pure desperation for space. But it directly contradicts best practices. I mean, if you look at guidelines from organizations like the Agency for Healthcare Research and Quality.
Right, HRQ.
Yes, exactly. They emphasize that care transitions are the most vulnerable moments for a patient. A ride home is not an afterthought. It is a vital continuation of care.
Which perfectly brings me to the person at the absolute center of this storm, the patient.
The one actually experiencing this.
Right. And, you as the listener have probably experienced a delay at an airport. The board flashes delayed and the time just keeps creeping back. It's incredibly frustrating.
Oh, it's the worst.
Right. But you sigh, you go buy an overpriced $12 sandwich, you read a book, you deal with it. I want to ask you, though, why is a 45-minute delay for a medical ride an entirely different psychological experience?
Because the context of vulnerability changes everything.
How so?
Well, at an airport, you have your autonomy. When you have just undergone a medical procedure, your autonomy has been stripped away. You are physically depleted.
You're not just annoyed, you're unwell.
Exactly. You might be reliant on a portable oxygen tank that only has 2 hours of battery life left.
Oh, no.
Right. You might be in significant pain and completely unable to stand. You might be staring at the clock because you know you need your next dose of medication.
Or you haven't eaten in 18 hours because you had to fast for a scan.
Precisely. So when you are sitting in that wheelchair and 45 minutes go by with zero communication, it isn't just a logistical hiccup. It is a really heavy psychological burden.
It feels personal.
It does. The patient starts spiraling. Did the nurse forget to call? Was the ride actually authorized? Am I sitting at the wrong exit doors?
Are they going to turn the lights off and leave me here?
Yes. Is the clinic staff going to lock up and go home, leaving me outside in the dark?
When you are trapped in a void of silence, waiting feels like abandonment. Human dignity doesn't end just because the doctor signed the discharge papers.
That concept of abandonment is so powerful because the person who usually absorbs that panic isn't the doctor, it's the caregiver.
The family member, usually.
Right. And I really want to highlight the caregiver's reality here because they are basically the unsung heroes acting as this remote command center. Often, they aren't even at the hospital.
No, they're usually at work.
Exactly. They are sitting at their desk 20 miles away, trying to subtly check their phone under the table.
And their phone is just blowing up.
Yeah.
The patient is texting them saying, "No one is here, I'm scared." So the caregiver leaves their desk, goes into the hallway, and just starts juggling.
Trying to fix a problem they can't even see. Exactly. They call a hospital switchboard, try to get transferred to the nurse's station, and ask if the discharge even happened. The nurse says yes. So the caregiver hangs up, calls the transportation broker, navigates an automated phone tree.
Which takes forever.
Always. They sit on hold and try to find out if a driver was even dispatched. And all the while, they are doing this agonizing mental math.
Right, like, do I leave my job right now, risk getting fired, and just drive to the hospital myself?
Exactly. It is an incredible amount of stress.
It sounds like an absolute nightmare of guesswork. Why is the caregiver forced to play detective like this?
Because the system lacks ownership.
What do you mean by that?
Caregivers are forced to guess their actual role. Like, am I just an emergency contact listed on a piece of paper in case something goes wrong? Or am I the designated project manager who is supposed to actively call and trigger this will call ride?
Nobody tells them.
Exactly. When no one formally hands over the baton, the caregiver inevitably ends up running the entire relay race out of sheer desperation.
Wow. Okay, let's look at the flip side of this equation. The transportation side. Let's talk about the drivers.
Yes, let's talk about the drivers.
Because if I'm being completely honest, when you hear stories of people waiting 3 hours, the immediate gut reaction is to blame the driver.
It always falls on them.
Right. We assume they stopped for coffee, or they just don't care, or they're terrible at their job. But I feel like you're going to tell me that's completely unfair.
It is the most profoundly unfair assumption in this entire ecosystem.
Why is that?
Well, it's human nature to blame what we can physically see, right? And the driver is the face of the delay. But the driver has the absolute least amount of control over the circumstances that created that delay.
Right. They're just following orders.
Exactly. They do not just materialize out of thin air when a nurse picks up a phone.
So what are they actually dealing with? What is the reality in the cab of that van?
Extreme compounding constraints. When a will call ride finally pops up on their digital dispatch tablet, that driver might be on the complete opposite side of the city.
Stuck in traffic.
Or they might be in the middle of safely securing an elderly passenger's bariatric wheelchair into the floor locks of their van, which is a process that takes time and absolutely cannot be rushed.
Wow, right. You can't just speed that up.
No. They might be stuck behind a garbage truck in a narrow alley. They might be approaching their Department of Transportation mandatory hours of service limits, meaning they legally cannot take another trip without resting.
Or they don't even have the right information from the dispatcher.
Exactly. I have spoken to drivers who arrived exactly on time, but the original request was so incredibly vague that they spent 30 minutes driving a massive wheelchair van in circles around a huge hospital campus.
Just looking for the right door.
Trying to figure out which of the 14 entrances the patient is actually waiting at.
And this brings up a massive safety issue. Because I can imagine if I'm a driver and I know Mr. Smith has been waiting for 2 hours, I feel immense guilt. I feel pressure.
And that pressure forces really bad choices.
Because they're trying to make up for lost time.
Exactly. A broken logistics system actively encourages unsafe behavior. The driver knows a human being is suffering, so they rush. They speed. They might skip the 4-point tie-down safety check on a wheelchair just to shave off 3 minutes.
Which is terrifying.
Or they might rush another passenger out of the vehicle, risking a fall.
I want to state this as clearly as possible for anyone listening. A late pickup should never, ever be fixed by creating an unsafe trip.
Never.
You cannot solve a logistical failure by compromising human safety. You just can't.
If you send a driver into the field with bad data, inaccurate locations, and unrealistic timelines, you are setting them up to fail, and you are actively putting patients at risk.
So we've looked at the nurses, the patients, the caregivers, and the drivers. The last piece of this puzzle is the dispatchers. The people sitting in front of the multiple computer monitors trying to make the math work. Why can't they just assign a van the moment a hospital calls?
To understand the dispatcher, you have to understand the capacity puzzle. Think about a scheduled trip.
Okay, like a standard appointment.
Right. Let's say a patient has a scheduled pickup to go to the doctor at 2 p.m. That trip is a known entity. It reserves a finite block of time on a specific driver's board. The dispatcher can confidently route around it. But a will call trip,
Yeah.
that is a ghost. It represents future demand at a completely unconfirmed time.
It's literally like playing Tetris, but the pieces are invisible until they are an inch from the bottom of the screen.
That is a brilliant analogy, and the dispatcher isn't just dealing with one ghost.
Right, there are dozens.
What happens when 4 different hospitals call within 10 minutes of each other at 4:30 p.m. right as rush hour traffic hits, and they all have will call patients ready at the exact same time?
The system just bottlenecks.
The dispatcher has to balance those waiting patients against all the other pre-scheduled rides that still need to happen. They have to match vehicle types. You can't send a sedan to pick up a patient who is now in a wheelchair.
Oh, right, you have to find the specific van.
Yes. They have to navigate insurance and Medicaid broker rules, which can actually require a human being to approve a code change before the van is even allowed to move.
Okay, so if we zoom out and look at this entire ecosystem, the nurses are drowning in clinical work, the caregivers are panic calling from their office, the drivers are fighting traffic and bad directions, and the dispatchers are playing impossible math games.
It's chaos.
Everyone is genuinely trying their best. Nobody's trying to do a bad job here, but they're all working in complete silos. And those silos are where the delays are born.
Exactly. The system is fundamentally designed to fail, but the good news is it fails in very predictable ways.
Right. So I want to move away from the abstract and get intensely practical for a minute. Let's trace the journey of our hypothetical patient, Mr. Smith.
Okay, let's use Mr. Smith.
So Mr. Smith just finished his dialysis. Through his story, let's unpack the 9 most common ways this system breaks down. How does a delay actually happen? Let's start with the most frustrating one.
The first failure point is the illusion of activation. The ride was simply never properly activated in the first place.
But wait, how does that even happen? If a nurse says they called, didn't they call?
Well, they called, but calling is not communicating. Imagine Mr. Smith's nurse, Sarah. She's incredibly busy. She sees Mr. Smith is done. She looks at a sheet of paper, calls the transportation provider's local office, and gets a voicemail.
Oh no, voicemail.
She leaves a message. Hi, this is Sarah at the clinic. Mr. Smith is ready. She hangs up and checks it off her mental list. In her mind, the ride is active.
But it's a black hole.
It is a complete black hole because in modern NEMT dispatch centers, voicemails do not automatically integrate into the dispatch routing software.
Right, a computer can't read a voicemail.
Exactly. A human has to notice the blinking red light on a physical phone, listen to the message, open Mr. Smith's digital file, and change his status from pending to ready.
Which takes time.
And if the dispatchers are overwhelmed with live calls, that voicemail might sit unheard for an hour. The clinic thinks a van is on the way. The dispatch center has absolutely no idea Mr. Smith even exists.
That is infuriating. Just totally avoidable. Okay, so let's say Sarah the nurse realizes voicemails are bad. The next week, Mr. Smith is in dialysis again. Sarah decides to be proactive.
Okay.
She knows Mr. Smith will be done in about 20 minutes. So she gets on the line, talks to a live human dispatcher, and says, send the van now.
Yeah, that sounds smart, right?
He's beating the system.
And she has just triggered failure point number 2, requesting the ride prematurely.
Oh, really?
Yes, this is incredibly common, usually driven by the facility's desire to clear space. The dispatcher receives Sarah's call, looks at the board, and sees a driver who happens to be 2 miles away.
Oh.
The dispatcher routes that driver immediately.
Okay, so the driver gets there fast.
The driver arrives at the clinic in 5 minutes.
But Mr. Smith isn't done. He still has 15 minutes of dialysis left.
Precisely. The driver walks in, and Sarah says, "Oh, he just needs 15 more minutes. Can you wait?"
Well, can they? What's the harm in sitting in the lobby for 15 minutes?
The harm is systemic collapse. If that driver waits 15 minutes for Mr. Smith, they will be late for their next pickup, which makes them late for the pickup after that.
The whole day is ruined.
The schedule is too tight, so the driver is literally forced by dispatch to say, "No, I cannot wait. I have to leave."
Oh, wow. So what happens to Mr. Smith? Does the driver just circle the block?
No, the driver goes to their next assigned patient, and Mr. Smith's file is kicked back to the dispatcher. He loses his spot.
Oh, no.
He doesn't just wait 15 minutes, he goes to the absolute back of the queue, waiting for a completely different vehicle to become available in that geographic zone. It could take 2 hours. Premature activation creates a massive penalty for the patient.
That blows my mind. Trying to be early actually causes the longest delays.
Yeah.
Okay, so Sarah learns her lesson. The following week, she swings the pendulum completely in the other direction.
Which leads to failure point number 3.
Right. Requesting the ride far too late.
Exactly. Sarah waits until Mr. Smith is completely unhooked from the machine. His coat is on, he's in a wheelchair, and she wheels him literally right up to the sliding glass exit doors.
Only then does she call.
Then she picks up the phone to call dispatch.
She treats it like hailing a yellow cab on a corner in Manhattan.
Exactly. She expects instant arrival. But the transportation provider now has to find a driver, potentially authorize the trip through a Medicaid broker, which takes time, and then the driver has to fight 30 minutes of crosstown traffic to get to the clinic.
So Mr. Smith is now sitting at the glass doors, fully dressed, staring at the parking lot for an hour.
Feeling completely forgotten.
It's all about precision timing. But how do you get precision timing when everyone is so busy? Which leads us right to failure point number 4.
The ownership gap.
Yes. The diffusion of responsibility. I always compare this to a high school group project. You've got 4 kids assigned to make a volcano, right?
Oh, I know where this is going.
Everyone assumes someone else is going to buy the baking soda. The day of the presentation arrives, and nobody bought it because everyone thought the other guy was doing it.
That is exactly what happens in a medical facility.
Let's look at Mr. Smith's hospital stay. The floor nurse thinks the social worker called the transport broker.
Right.
The social worker assumes Mr. Smith's daughter, the caregiver, called the transport company from her phone. Meanwhile, a shift change happens at 3 p.m.
The deadliest time in a hospital.
The new nurse comes on duty, looks at Mr. Smith sitting in the chair, and just assumes the previous nurse confirmed the vehicle.
Because the department is handling it.
Right, but the department cannot own a task.
Only a specific, named human being can own a task. When a process touches multiple hands, but no one is explicitly named as the absolute owner of the final activation, the process simply halts. Mr. Smith sits there for hours because literally everyone thought someone else pushed the button.
Okay, let's say someone finally pushes the button. We hit failure point number 5, the physical geography of the hospital. Location changes.
Right, because hospitals are not just buildings, they are sprawling, complex campuses.
Oh, they're like small cities.
Exactly. Let's say Mr. Smith was admitted through the emergency department. His original transport record says pick up at ED doors, but by 2 p.m., the ED is slammed with trauma cases.
They need his bed.
So they medically clear him and move him to a quiet discharge lounge on the complete opposite side of the hospital campus in, let's say, the North Pavilion.
But they don't tell the transportation company.
They never tell the transportation company. So the driver gets the alert, drives to the emergency department, walks in, and asks the desk for Mr. Smith.
And he's not there.
The desk looks at the computer and says, he's not here. He was discharged from this unit 2 hours ago.
So the driver thinks he already left.
The driver assumes Mr. Smith caught a ride with family, marks it as a no-show, and drives away. Meanwhile, Mr. Smith is sitting in the North Pavilion discharge lounge, wondering why he's been abandoned. The left hand has absolutely no idea what the right hand is doing.
That is heartbreaking. It's a literal missed connection. Okay, failure point number 6. This one gets into the medical details. Incorrect mobility or equipment information. What does that actually mean practically?
It means the patient's physical reality has changed, but the data hasn't.
Give me an example.
Let's say Mr. Smith took a standard sedan to his morning appointment. He walked out of his house and got in the back seat. But during his treatment, he became incredibly weak.
Which is super common with dialysis.
Very common. So the clinical team decides he cannot walk to a car safely. He must be transported home in a wheelchair.
That seems like a responsible medical decision.
It is. But when the nurse calls to activate the will call ride, all she says is, Mr. Smith is ready. She doesn't explicitly state Mr. Smith's mobility status has changed. He now requires a wheelchair-accessible vehicle.
Oh, I see where this is going.
So the dispatcher, looking at the morning record, sends the standard sedan back to get him. The driver pulls up, walks in, sees Mr. Smith in a wheelchair, and realizes he physically cannot lift Mr. Smith into a sedan.
So the ride was activated perfectly, the timing was great, the location was right, but the physical completion of the trip is completely impossible.
Wait, and it's not just wheelchairs. It's failing to report that Mr. Smith is now discharging with a heavy bariatric wheelchair that requires a stronger lift.
Or forgetting an oxygen tank.
Or forgetting to mention he now has an oxygen tank that needs to be secured. Or that the hospital requires his daughter to ride with him as a medical escort. If the vehicle sent isn't legally equipped or authorized for those specific changes, the trip aborts on the spot.
I can't even imagine the frustration of seeing your ride pull up, only to be told you can't get in it.
It's devastating.
All right, failure point number 7. And this one is entirely about human psychology. Unclear pickup expectations.
This is where language matters more than anything. A well-meaning nurse walks into Mr. Smith's room, smiles, and says, "Great news, Mr. Smith. Your ride is called."
Which sounds fantastic. If someone says that to me, I'm grabbing my coat and expecting to leave right now.
Exactly. In the patient's mind, called translates directly to arriving in 5 minutes. But the reality is, the dispatcher told the nurse that due to rush hour, the estimated pickup window is between 60 and 120 minutes.
But she didn't want to tell him that.
Right. Because the nurse didn't want to deliver bad news or wanted to make Mr. Smith feel good in the moment, she used vague, overly optimistic language.
She set a completely impossible expectation.
She did. And when minute 15 rolls around and Mr. Smith is still sitting there, he feels betrayed. He feels anxious. Honest communication is vital, even if the truth is uncomfortable. You have to tell the patient the real timeline.
Wow. Okay, failure point number 8, driver and vehicle availability. This goes back to what we discussed earlier. Sometimes it's just raw logistics, right?
It is.
Yeah.
Even if the facility does everything perfectly, they give the right location, they update the mobility to a wheelchair, they call at the exact right time, the geographic reality might be that the nearest available wheelchair-accessible van is 45 minutes away on a completely different route.
Because there are only so many vans.
Exactly. Or, in some Medicaid managed care structures, the local provider might not have a van available at all, so the request has to bounce back to a state-level broker to find a completely different company to take the trip.
That sounds like a lot of red tape.
That administrative loop alone can add an hour to the wait. The supply of vehicles is not infinite.
And that leads to our final failure point, number 9. When the system breaks, how do we react? The lack of an escalation procedure.
This is the definition of insanity in this industry.
What happens when the promised window passes? Let's say they told Mr. Smith the van would be there by 3 p.m. It is now 3:20 p.m.
In most facilities, there is no documented plan B. The staff just panics, calls the exact same phone number, talks to the exact same overwhelmed dispatcher, and gets caught in an endless loop.
Just being told. They're on their way, they're 5 minutes out.
Just hoping and praying the van shows up.
Exactly.
There's no structured escalation ladder. No defined trigger to contact a supervisor. No procedure to evaluate alternative transportation options. They just keep Mr. Smith waiting in a void.
Okay, I have to take a deep breath. Because looking at those 9 failure points, I mean, it feels overwhelming.
It's a lot.
It feels like a sinking ship with holes everywhere.
Yeah.
But I know we aren't just here to admire the problem today.
No, absolutely not.
How do we plug the holes? How do we build a rescue mission for Mr. Smith? Because I know you have a blueprint, a very specific 10-step coordination system to actually fix this.
It is a blueprint, but I want to be very clear about expectations here.
Right.
The goal of this system is not to magically eliminate every single minute of waiting.
Right, because that's impossible.
That would be biologically and geographically unrealistic. Traffic exists, medical emergencies happen. The goal of this 10-step system is to eliminate preventable confusion, establish undeniable ownership, and ensure that no patient ever becomes invisible while they wait.
Okay, I love that. Preventable confusion. I'm going to play the role of the skeptical hospital administrator here. Okay.
Go for it.
I want to know how this actually looks on the ground. Step 1 is early planning and identification. How does that work in reality?
It means we stop treating transportation as a surprise that happens at discharge. Will call must be identified before the patient even arrives for their appointment.
So days in advance.
When the trip is initially booked days in advance, the digital record must explicitly flag the return trip as a will call. Furthermore, the intake team needs to capture comprehensive details.
Like the exact doors.
Not just General Hospital, but North Pavilion, Main Lobby, Door 4. They need current mobility info, and crucially, they need to establish backup contacts.
So you're managing expectations days before the appointment even happens.
Exactly. The patient and the caregiver are told on Tuesday, hey, for your procedure on Friday, your ride home will be a will call. That means you might have to wait a bit after you're done while we route a van to you. You remove the shock value of the wait.
Brilliant. Okay, step 2. One assigned activation owner and a backup. This fixes our group project problem. How do we do that?
By completely banning the phrase the department is handling it. Every single patient chart must have a named individual responsible for the ride home. Depending on the facility's workflow, that might be the dedicated discharge planner, a specific unit clerk, a social worker, or even an authorized family caregiver.
But it's a specific name.
But it is explicitly documented. Sarah is the transport owner for Mr. Smith, and if Sarah goes on her lunch break, she doesn't just leave, she formally hands the baton to her designated backup. Accountability becomes unavoidable.
I love that clarity.
Yep.
Now, steps 3 and 4 go together, and this is where I think the biggest arguments probably happen in hospitals. Clear ride readiness standards.
This is a huge point of friction.
I have to push back here. What does done actually mean? Because to a doctor, done means the incision is closed and the chart is signed.
Right.
To a patient, done means they're wearing their shoes and holding their coat. To a nurse, done might mean they just need to print one more piece of paper. Who gets to decide?
That ambiguity is exactly what causes premature activations. Done is the most dangerous word in a hospital. To solve this, facilities must adopt a staged readiness system.
Like a countdown.
Think of it like a countdown to launch. First is the planning phase. We know Mr. Smith needs transport today, but we don't know when. A few hours later, we enter the approaching readiness phase.
Okay. Is that when you call the van?
No. Approaching readiness just means the medical procedure is wrapping up. The clinical team might give the transport provider a digital heads up if the software allows it, just to say, hey, he might be ready in an hour, but you do not dispatch a vehicle.
So when do you call?
You only dispatch a vehicle when you reach the third phase, ride ready.
Okay, define ride ready for me. Give me the actual checklist.
Ride ready is a strict, non-negotiable operational standard. It means the patient has been medically and formally released by the attending clinical team.
Check.
It means all discharge instructions have been explained to the patient. It means all new prescriptions are either physically in the patient's hand or have been electronically routed and confirmed at an outside pharmacy. It means their personal belongings are bagged. It means they are dressed in appropriate street clothing and footwear, and it means their mobility equipment, like their personal wheelchair, is physically in the room with them.
So there are absolutely no lingering tasks. None.
Zero. Only when every single one of those boxes is checked does Sarah, the assigned owner, pick up the phone to activate the will call ride.
And is there a phase after that?
Yes. The final phase is handoff ready. That means Mr. Smith has been moved from his room to the designated pickup lobby with whatever staff monitoring is required by the hospital's policy, and he is actively waiting for the van to pull up.
That staging system completely eliminates the guesswork of, is he done? Okay, step 5. Closed loop activation. This is how we kill the voicemail black hole, right?
It is the absolute antidote to the black hole. We have to institute a rule. Voicemails do not equal activation. Never. When Sarah requests the activation, that request must be received, documented, and explicitly acknowledged by the transportation provider. The loop is not considered closed until Sarah receives 2 specific pieces of information back from the dispatcher.
Which are?
A unique confirmation number and an estimated pickup time window.
So if Sarah leaves a voicemail, she cannot check it off her list until someone literally calls her back with the number.
Exactly. If you don't have a confirmation number, you do not have an active ride. Period.
Which bridges perfectly into steps 6 and 7, realistic windows and scheduled updates. And I know you are incredibly passionate about the exact scripting used here because it goes back to that psychological trauma waiting we talked about.
I am fanatical about this. Words create realities for patients. We have to completely banish phrases like, someone will be there soon, or they're on their way.
Why? I mean, they sound nice.
Those phrases are toxic to a patient's trust because they are meaningless.
Right, because soon to me means 5 minutes. Soon to a dispatcher handling 30 vans means an hour. So what is the exact script Sarah should use when she walks into Mr. Smith's room?
She should use precise, verifiable data. She should look Mr. Smith in the eye and say, Mr. Smith, I personally activated your ride at 2:10 p.m. The transportation company gave me a confirmation number. Based on current traffic, their estimated pickup window is between 3:10 and 3:40 p.m.
Wow, that's specific.
I know that's a bit of a wait, but I am going to check their system and come back to give you another update at 2:50 p.m.
That completely changes the psychological dynamic.
It really does.
You aren't promising a fast ride, but you're promising control.
Control and visibility. Mr. Smith isn't staring at the door wondering if he's forgotten. He knows exactly when the next piece of information is coming, and the system should support this. Modern transport software can send automated text messages at key milestones.
Like tracking a package.
Exactly. Vehicle assigned, driver en route, driver pulling up. The patient shouldn't have to beg for information.
Okay, step 8. And I want to spend a moment on this one because it strikes at the absolute core of human dignity. Establish a safe indoor waiting location. We talked earlier about that horrific pressure to just push a vulnerable patient out to the curb so the hospital can clean the bed.
That practice has to end. It simply cannot be the standard of care. Facilities must have a designated waiting protocol that is appropriate to the patient's medical needs.
So what does a proper waiting area actually look like?
It is not a bench by the sliding doors. It means protection from extreme weather. It means comfortable, supportive seating, not just hard plastic chairs.
Right.
It means immediate access to wheelchair-accessible restrooms. If a patient is waiting for an hour, they need access to a water fountain. They might need a wall outlet to charge their cell phone so they can text their caregiver or, to charge a portable medical device.
And they need to be visible.
Crucially visible. They need to be in a line of sight for hospital staff so they can be monitored just in case their medical condition suddenly deteriorates while they wait. Do not banish patients to a forgotten hallway just to make a driver's pickup slightly faster. The transition to the vehicle must be controlled, safe, and dignified.
Okay, step 9. We have our system, but reality happens, right? A snowstorm hits, a van breaks down, the promised time window passes. We need a documented escalation process. No more just calling and asking where are they.
Exactly. It needs to be a flowchart, not a guessing game. If the window passes, say it's 3:41 p.m., Sarah doesn't panic. She executes the escalation ladder.
Walk me through the ladder.
Step 1. She contacts the provider to confirm the trip hasn't been accidentally canceled. Step 2. She demands a precise GPS-based vehicle status, not just they are close.
You want coordinates.
Exactly. Step 3. If the delay is deemed unacceptable, she doesn't argue with the dispatcher. She escalates immediately to a transport supervisor or the state broker.
Because the dispatcher can't fix it anyway.
Right. Step 4. She notifies Mr. Smith's caregiver immediately, so his daughter isn't sitting at work having a panic attack.
Keep the family in the loop.
And step 5. She evaluates pre-approved alternative transportation options, like a contracted taxi service or a facility-owned shuttle, keeping in mind whatever insurance payer rules apply.
It's methodical. It removes the emotion and replaces it with action.
Which is exactly what you need in a crisis.
And finally, step 10, confirmation of final handoff.
This is a critical distinction that completely skews hospital data. A lot of facilities track when a vehicle arrived. That is an event. Patient transported is an entirely different event.
Wait, explain that to me. If the van is there, isn't the patient transported?
Not always. The logistical process does not end just because a white van pulled into the circular driveway. Closing the loop means a human being, Sarah, or a designated greeter, physically verifies that the correct passenger is boarding the correct vehicle.
You would be absolutely terrified by how often a driver pulls up, asks for John, and a completely different patient named John gets in the van. Wait, you're kidding?
It happens. Or the driver tries to load Mr. Smith, but forgets his bariatric walker on the sidewalk. Or the driver inputs the wrong home address in the GPS. Handoff confirmation means someone physically verifies the patient, the equipment, the belongings, and the destination before those van doors close.
Wow. That is how you close the loop safely.
Yes.
Okay, looking at this 10-step blueprint, it is a beautiful, robust system. It would change the lives of millions of patients. But as I look at it, I realize that this entire architecture relies on one fundamental thing.
What's that?
A massive amount of data sharing. Sharing detailed information between the hospital nurses, the transportation company, the driver on the road, and the caregiver at home.
Yeah.
And anytime you talk about sharing information in American healthcare, massive alarm bells go off.
And they absolutely should. That brings us to our final crucial area to explore: data, privacy, and systemic improvement. We cannot fix this system if we violate patient privacy in the process.
Right, because we have HIPAA, the Health Insurance Portability and Accountability Act.
Yeah.
It is drilled into every medical professional's head to protect patient information at all costs.
But I imagine that fear of violating HIPAA sometimes actually paralyzes this transportation system, right?
It does. It is a massive barrier, largely due to misunderstanding the law itself. Staff will use HIPAA as a shield to withhold vital, purely logistical information from the transportation providers. They'll say, I can't tell you anything about the patient, just send a van.
So how do we balance the absolute legal need for privacy with the physical need to get Mr. Smith home safely?
We rely on what the U.S. Department of Health and Human Services calls the minimum necessary rule.
The minimum necessary rule.
Okay. Organizations are required to make reasonable efforts to limit the disclosure of protected health information to only what is strictly necessary to accomplish the intended purpose. Okay, so let's apply that. What does a transport dispatcher or a driver actually need to know? Obviously, they don't need to know the results of Mr. Smith's blood panel or his psychiatric history or the intimate details of his surgery.
Correct. They do not need and absolutely should not have his clinical medical history, but they absolutely, unequivocally need his operational data.
What falls under operational data?
They need to know his exact mobility status. Does he require a wheelchair lift? Can he transfer to a seat or must he remain in the chair? They need to know his boarding requirements. Is he traveling with a heavy, explosive, portable oxygen tank?
Right. Safety issues.
Is he accompanied by a legally recognized service animal which the driver cannot legally refuse? Is a family escort required to ride with him due to cognitive decline? And they need his correct emergency contact numbers.
So sharing that operational data isn't a violation, it's an absolute safety requirement.
Exactly. Withholding that operational information under the guise of HIPAA does not protect the patient. It actively endangers them by sending an unprepared driver into a really complex situation.
Now, speaking of endangering patients, I want to pivot and strictly remind our listeners of a very fundamental unbending rule of this entire industry. We are talking about NEMT, non-emergency medical transportation. It is right there in the name.
It is the most important word in the entire acronym, non-emergency.
So let's go back to Mr. Smith. Let's say the system breaks down. He's been waiting in the discharge lounge for 2 hours. He is exhausted. Suddenly, he starts experiencing severe chest pains.
Oh, wow. Okay.
Or he becomes extremely short of breath. Or he becomes completely unresponsive in the chair. What do? Do you call the dispatcher and yell at them to hurry up?
Absolutely not. You do not wait for the NEMT van to arrive. You do not escalate to the transportation broker. NEMT drivers are not paramedics. Their vans are not ambulances.
So what is the protocol?
You immediately escalate to clinical care. If you are inside a hospital, you follow your facility's rapid response or emergency procedures. If you are a caregiver waiting at a small outpatient clinic, you dial 911 immediately.
I just want to underline that in permanent marker for everyone listening. A scheduled or will call ride is never, ever a substitute for emergency medical services. If the medical situation changes, the transport plan changes instantly.
That is a critical boundary that can never, ever be crossed.
Okay, assuming Mr. Smith is medically stable, and we are just dealing with standard operational delays, how do we actually improve this massive ecosystem over time? Like, how do we know if our 10-step blueprint is actually working?
Through rigorous performance measurement, we have to look at the data, but we have to look at it very differently than we have in the past.
What do you mean by differently?
We need data without blame. Historically, hospitals and transport companies use data to point fingers. Your drivers are always late. Well, your nurses always call too early.
Just fighting back and forth.
That gets us nowhere. We need to track specific metrics to find the broken process, not to punish the person.
So what should a hospital administrator or a transport fleet manager actually be tracking on their dashboards?
They need to track the delta between the steps. What is the average time from when a ride is activated to when a vehicle is actually assigned on the board? What is the average time from that assignment to the physical arrival?
To see where the bottleneck is.
Most importantly, what percentage of pickups are successfully completed within the time window that was explicitly promised to the patient?
And you can track the failures too, right? Like the number of times a facility requested a ride prematurely, or the number of times a driver arrived but went to the wrong entrance.
Exactly. And here is where the without blame part comes in. If a facility notices that drivers go to the wrong entrance 40% of the time, they don't call the transport company and scream at the drivers.
They look at themselves.
They look in the mirror. They realize their own facility's digital trip request forms have vague entrance descriptions, or they haven't updated their campus map in the transport database. So they fix the form. They fix the system to prevent the next patient from experiencing that same failure.
It's about systemic evolution, not personal punishment.
Wow, this has been a truly eye-opening deep dive. We've covered a tremendous amount of ground today, from the psychology of waiting to the dispatcher's Tetris board to the 10-step rescue mission.
It's a massive topic.
Let's synthesize all of this, because when a facility and a transport provider actually collaborate to implement this kind of coordination, the ripple effects are staggering. It literally benefits every single person in the ecosystem.
It really does transform the environment. I mean, for the healthcare facilities, a dependable, transparent will call process means smoother, faster, safer discharges.
Right.
It means protecting valuable clinical staff time, because trauma nurses aren't spending 2 hours on hold with brokers. They are back at the bedside where they belong.
And for the transportation providers, receiving accurate, timely information means safer vehicle assignments, fewer wasted trips, and highly realistic routing.
And think about the drivers. The folks out there actually navigating traffic, dealing with the elements. This system reduces that crushing, unfair pressure on them. It stops the confusion of incorrect entrances, and it completely prevents those awful, tense confrontations where a driver walks in and is screamed at by a patient for an expectation the driver didn't even create.
Exactly. And for the caregivers, it removes the agonizing burden of having to be a remote air traffic controller from their desk at work. It gives them visibility and peace of mind knowing a system is handling it.
And most importantly, for the patients like Mr. Smith.
Right. For the patients, it replaces profound fear and uncertainty with a visible, dignified, and managed plan.
And look, we have to acknowledge reality. As you said earlier, no system is perfect. No checklist can magically guarantee that a shiny, perfectly heated van will be waiting at the curb the exact second a doctor signs a discharge paper.
Yeah.
Healthcare is inherently unpredictable. City traffic is unpredictable.
But while we cannot guarantee a 0-minute wait, we can guarantee that the patient is seen and acknowledged.
Yes.
We can guarantee that responsibility for their journey is explicitly clear. We can guarantee that honest, scheduled updates are communicated directly to them.
As we wrap up this deep dive, I want to circle back to where we started today. I asked you to imagine that patient sitting in the lobby, bags packed, exhausted, appointments are over, waiting in that terrifying gap.
And I want to leave you with a final thought to mull over regarding that gap. Consider how the immense psychological weight of waiting is completely transformed based entirely on the flow of information.
How so?
Waiting an hour in a void of total silence with no one making eye contact feels like absolute abandonment. It is a traumatic way to end a care journey. But waiting that exact same hour in a comfortable chair with a clear promised update every 20 minutes from someone who knows your name feels like being safely managed.
The gap between a traumatic care transition and a smooth, dignified one isn't necessarily about driving the vans faster. It is often just about a few properly communicated data points and a little bit of empathy.
It all comes down to human connection and respect.
Thank you so much for joining us on this deep dive. We hope it changes the way you look at the journey home and maybe helps you advocate for yourself or a loved one the next time you find yourself waiting in that lobby. To learn more about building professional, transparent, and people-first transportation, visit www.swiftaidtransport.com.
The medical visit may be finished, but our responsibility to the patient is not complete until the ride home is safely underway.